And as you know, nausea and vomiting can be caused by lots of things, one of which includes abdominal pain. So we're going to just kind of briefly talk about some things to talk about there. And then at the end, if we have time, for any questions you guys have or any interesting cases that you've had, that you could share with us, and maybe we can learn from some of the weird, interesting cases you may have had in your careers. So I will need a volunteer, and there's two cases, so I'll need eventually two volunteers. If you volunteer, you're probably going to learn more. It'll stick in your brain. All right, Harrison, I'm gonna make you pick a volunteer based on who's been the 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 worst or the best in class last week.
I'm gonna pick Non Lee.
Awesome.
Non Lay.
Is it
It's an honor.
is it Dr. Lee? Is that right?
My name's Young. Lee is my first name. My family name.
Okay, okay. Well, thank you. So case one, here we go. You've got a 48-year-old male brought in by wife who presents with abdominal pain. Um, what would you like to do, or what would you like to know?
So I would want to ask about the size of the abdominal pain as well as it is a characteristic. Uh, I,
Yeah.
uh,
So it's she or he says it's 7 out of 10. It's kind of diffuse. The whole abdomen hurts. He just says it hurts all over, doctor. It hurts all over.
any accompanying symptoms?
Uh, he says he's had some chills, kind of intermittently, maybe some sweating, but he hasn't checked a fever at home. Otherwise, he doesn't mention much. He is with his wife too, but
Does he have any kind of disease that I should know about? Any medication or bus surgery record?
yeah, he has a past medical history of hepatitis C, and associated with that is he is in the stage of cirrhosis now. He's got some kind of off and on kidney disease as well. Otherwise, no major medical problems. He currently doesn't take any medications.
Uh, and I was some information about his vitals, FEED.
Yeah, so here are your vitals. Heart rate's 98, blood pressure 98/60, respiratory rate 18, 96% on room air, temperature of 37.9, and he weighs 70 kilos.
Can I ask about his physical examination, or is it the next part
Yeah, you can ask
at
with
this
the
point?
physical exam. Definitely. What do you want to know about the physical exam?
Overall, and also the abdomen examination.
Yeah, so overall, he does seem kind of sleepy, drowsy, but he's able to wake up and answer your questions. He's not in any kind of distress. He doesn't look like he's in horrible pain or his abdomen is distended, you know. You also note that no matter where you press, he says it hurts. There's no rebound or guarding though. Normal bowel sounds, and you don't feel any masses or hernias.
Hmm.
Uh, just to finish out the exam, just to cover, he's got a little bit of edema or in his extremities, below his knees. His neuro exam, like I said, he's a little bit drowsy, but he wakes up, answers questions. No focal deficits. He's moving all four extremities. His skin is kind of warm and dry. Um, he's got a little bit of bruising around, but nothing crazy. Was there anything else specific about the physical exam you wanted to know?
I think I get enough information, but because I missed the class the last week because of my shift, so I don't know how I'm supposed to run this kind of case. So can you? So
You're
at
doing,
this point,
yeah, you're doing great. You're doing great.
should
I
I
can,
move on to the diagnosis or some more tests?
yeah, yeah, I can, here, let me click through. I've got just a couple of things on this page, which you've kind of already addressed. You kind of got some questions. Yeah, here, if you have any actions that you want to do just right now, initial actions, um, or like tests you want to order.
So first of all, his heart rate and blood pressure are not very normal because of it. So I would like to run some IV line first. And I also some test on his CBC, CMP, coagulation panel, as well as a quick ultrasound.
Okay, perfect. On your ultrasound, what are you looking for?
Is there any free fluid or maybe air?
Okay, perfect. So are you kind of doing a fast exam or something else?
Yeah, maybe fast exam.
Okay. Yeah. So here's some actions that I had recommended you. The getting an IV, like you said, getting some blood off, giving some fluids because of the low blood pressure and high heart rate. I think in a patient who's kind of altered, always checking a glucose and then an EKG as well, um, while you're kind of getting everything going. But yeah, here's some questions that you asked most of these. Past medical, surgical you asked about. There's no important really family history. It's always important to ask kind of allergies early on. Um, as far as his symptoms, they've been going on for 3 days and just getting slowly worse. And the pain is constant throughout his entire abdomen, and no significant associated symptoms other than the sleepiness and the occasional chills. So here's kind of we talked about most of these already as you asked about him, but he did have hepatitis C. He's a cirrhotic. He has a past surgical history. He did have esophageal banding a year ago for some esophageal varices. Otherwise, no meds, no allergies. He used to drink a lot of alcohol, but doesn't anymore. And he is full code. We talked about the physical exam. Your nurse does want to update you, though, that his temperature is now 39.2 degrees Celsius. Um, yeah, and you mentioned some of the actions. Any actions that you'd like to add? Specifically, what blood work would you want to get? And is there anything else? You mentioned ultrasound, but anything else you'd want to do?
If I get Mr. High Fever, I suspect he might have the sepsis. So I'm going to order some blood culture.
Perfect. Perfect. Awesome. And then what's on your differential diagnosis right now? It's probably pretty big. That's okay.
Yeah, the picture is very clear. So at this point, I'm thinking that maybe because of this real pain, I think that maybe bowel obstruction or maybe bacterial peritonitis.
Perfect. Yeah, those are good
Uh,
ones. Anything else that you're thinking about?
uh, Perforation,
Yeah.
maybe perforation.
Yeah, I think any kind of perforation could cause this as well, kind of the diffuse pain. Perfect. So here you already asked for the ultrasound. Here's kind of your fast exam. You have your right upper quadrant, left upper quadrant, and suprapubic. Um, what do you notice here?
There's free fluid everywhere and some distended bowel in
Yeah,
the suprapubic view.
totally, totally. And here's one more view of just oh, never mind. Sorry. So yeah, okay. So what do you want to do with this information?
Maybe at this point, I want to order a CT scan to rule out all of the differential diagnosis. But the ultrasound is not really suggested to me, but in some cases, the patient can have fluid in their abdomen.
Yeah, perfect. I think a CT scan is on the way. There's a couple of patients that are in front, so we're not going to get a CT scan back during the case, unfortunately. Is any procedures that you might want to do?
Teacher.
You mentioned your concern for bacterial peritonitis.
Um, I'm forgetting the word. The word.
Yeah, so you want to collect the fluid. Is that?
Yeah, correct.
Yeah,
I'm
so
forgetting the word.
yeah, no, all good, all good. The English word is paracentesis, which I don't expect you
Uh,
to
yes,
I don't expect you to remember that
yeah.
word. It's hard for me to remember it, so
Paracentesis.
yeah,
I
so
only remember the word just synthesis, but I don't remember the word. That is
okay, perfect. So here's a view on your ultrasound. You have a big pocket of air, or of sorry, of fluid. You get your peritoneal fluid back, and this is the results of that peritoneal fluid. Does this give you a diagnosis or no?
the peritoneal fluid is cloudy and have sound.
So the PMNs is the polymorphic neutrophils. So that's your neutrophil percentage there. So 92% are neutrophils of the 400.
I think it may be very suggestive of the bacterial peritonitis.
Yeah, I completely agree. All right. Here's your blood work. I can kind of shout out the abnormals. The sodium's a little low. The creatinine is 2.6. The white count's elevated at 15.2. Hemoglobin's maybe a little low. Platelets are a little low. INR is a little elevated at 1.7. AST, ALT elevated. The bilirubin's elevated. Albumin's on the low side. A little bit of bump in the lactate. Ammonia is 115. And the urine and the trope are normal. What did these labs tell you about the patient history
So,
going on right
so
now?
definitely I can notice some infections with the high white blood cell count, also some very low platelet count. The albumin is decreased as in his cirrhosis,
Hmm.
and also elevated ammonia,
Yeah.
115.
Yeah, exactly. So in general, I think to summarize, it looks like this patient does have cirrhosis with the low albumin, low platelets, the INR being elevated, and also the bilirubin being elevated. And then the ammonia is high. And this patient does have a kidney injury or potentially chronic kidney disease if we don't know a baseline, but the kidney function is certainly not good. All right. Uh, so that's the end of the case. Awesome job. You got the diagnosis. Um, So the primary diagnosis is the spontaneous bacterial peritonitis. And it is important, as we'll talk about in a second, to differentiate whether or not this is spontaneous or secondary. But in this case, it was spontaneous bacterial peritonitis in the setting of a patient who has cirrhosis. Secondarily, the patient does have hepatic encephalopathy and as well as acute kidney injury. On the hepatic encephalopathy noted based on the patient's sleepiness, if you'd asked specifically during the physical exam, he also had that asterixis where the hands flap. If you kind of have them stretch it out, kind of flaps. He did have that, and then his ammonia levels elevated as well. So that's kind of how you clinch that diagnosis. Some of the critical things to do, getting the IV access, starting the fluids because of the hypotension and tachycardia, perform an ultrasound, you'll find the ascites, do a paracentesis, and then get cultures and start antibiotics. In this case, a third generation cephalosporin. Cefotaxime is preferred, but really, I think any third generation cephalosporin that you have is a good option. But if you do have cefotaxime, there's one study that showed it was actually superior to ceftriaxone in the treatment of spontaneous bacterial peritonitis. And of course, you have to admit these patients. Any any questions about the case, and then we'll talk more about these diagnoses and how to diagnose and treat them. All right. So SBP, just a brief definition. It's an acute infection of the peritoneal fluid without evidence of other intra-abdominal surgically treatable sources. So it's spontaneous. There's not like appendicitis or cholecystitis, pancreatitis, anything like that. There's no surgical problem at the moment. So the pathophysiology is not perfectly understood, but in some part it involves translocation of the bacteria from the lumen of the colon into the peritoneal fluid. So the gut gets out of the GI tract into the mesenteric lymph nodes and then into the fluid. Some contributing factors include bacterial overgrowth, impaired liver function, and portal/hepatic hypertension. And so the impaired liver function in cirrhotic patients, their phagocytes or the white blood cells in the liver don't do a good job anymore of killing bacteria like they used to. And then on top of that, there's all this hypertension leading to stasis of kind of the blood flow, and which allows the bacteria to grow faster. So most cases of SBP are going to be one organism. And it's usually going to be a gram-negative organism because it's coming from the colon. And so E. coli is the most common, but you'll also get some Klebsiella pneumonia. Occasionally it's gram-positive. I think the big takeaway from this is like you're always going to give that third generation cephalosporin. If patients are septic, like in septic shock, I would go ahead and cover for gram-positives as well and give like vancomycin. But if they're not in shock, I think giving the ceftriaxone and then waiting for a gram stain or the culture to come back would be pretty reasonable. The clinical presentation, it's not always very straightforward. So I think you have to have a really low threshold to get a paracentesis. If a patient is a known cirrhotic and they have a fever, but no abdominal pain, I would still do the paracentesis. Vice versa, no fever, but they have abdominal pain, I would be getting a paracentesis. I would also consider it in a patient who has just like nausea, vomiting, and no known cause. If you think it's could be related to the ascites, I would get the paracentesis because it's a hard to diagnose. Patients don't always present in the same way. And if it's not untreated, the mortality is really high. And in fact, 13% of patients with SBP will have no signs or symptoms during their initial presentation. So you have to be kind of on high alert, but you can have all these things: altered mental status, fatigue, malaise, diarrhea. So just keep your kind of eyes peeled for this diagnosis. As we talked about, to diagnose, we're going to do a paracentesis. Everyone has had quite a bit of experience with paracentesis? Has anyone not had experience? And we can kind of talk about it more, but I'm assuming everyone's done it probably many times. I know when I was over there last year, I know you guys had told me you did quite a few of these. Okay. So yeah, you want to get the fluid before you start antibiotics. There was a study that showed even a single dose of antibiotics dramatically reduces the likelihood of a gram stain and culture growth, which makes it difficult for us to guide our antibiotic choice. So try to get the paracentesis first. You don't need to do a therapeutic paracentesis, meaning you don't need to get a lot of fluid. You don't need to empty their belly. Just fill up a syringe worth of fluid. It shouldn't take you too long. Use ultrasound to find a big pocket, clean it down, put a needle in, suck out the fluid, and you're done. Should be pretty fast. The other thing to note is that a lot of cirrhotics are going to have an elevated INR. And so you might have some pause there and be concerned that since their INR is high, you could cause a lot of bleeding. In general, INR is not a contraindication, and you don't need to treat the INR. You don't need to give FFP or anything else. You can feel okay that they're still going to clot and that this is not a high bleeding type of procedure. If you are going to pick a spot, usually the left lower quadrant is the best. But the ultrasound, like I said, can really help you find the best pocket. Do avoid areas where there's surgical scars because there's a chance that there's adhesions where the scar is from the surgery and the bowel. And if there's an adhesion, normally your needle actually can push the bowel a little bit out of the way. But if you have an adhesion there, the needle can cause some serious damage to the bowel. Um, and then consider giving albumin within 6 hours. The dose would be 1.5 grams per kilogram. This has been shown to decrease renal failure and also decrease mortality if the patient has an elevated creatinine or an elevated total bilirubin. So it doesn't have to happen immediately. You could probably make this decision in conjunction with the team you're going to be admitting to. But in general, try to give some albumin when you're taking fluid off the belly. So once we've gotten that fluid, we need to know how to interpret it. The absolute neutrophil count is the main thing we're looking for in the emergency department. So sometimes, at least in America, that's listed as the polymorphic neutrophils or PMNs, and the number is 250. So if there's more than 250, we consider that SPP, and we'll go ahead and treat. Sometimes too, you can get just a percentage, so you don't get an absolute number. You get a percentage of neutrophils, like we did in this case. We had 90% neutrophils, and we had 400 white cells. So we just take 400 times 0.9, and we would get 360, if I did my math correct, which is greater than 250. And then in the case of a traumatic paracentesis, and you're concerned that you've taken blood from one of their veins and introduced it into the needle, you can just subtract 1 neutrophil per 250 red blood cells. So if there's like a really bloody tap, that's what you want to do. Another note on ultrasound, if you use ultrasound, you can look before you poke in that area to see if there's a vein in that spot on the skin. So you might want to even use the linear probe, which has the most detail. Put it on like you only see the first 1 or 2 centimeters, and make sure there's not a big blood vessel in that area before you do the paracentesis. Here's some other stuff that will show up on the blood work that can help suggest that this is spontaneous bacterial peritonitis. That's a pH of less than 7.35, the blood to ascites pH gradient of 0.1, the SAG of greater than 1.1, protein less than 1, and a glucose greater than 50. So these are some supporting, but the neutrophil is really the diagnosis. I mentioned this a second ago, but you do want to differentiate this from secondary bacterial peritonitis. And so if a patient is a cirrhotic, they have known ascites, it's probably spontaneous, but do consider there's a possible there was an underlying infection to begin with, whether that was a cholecystitis, appendicitis, pancreatitis, a bowel obstruction, diverticulitis, whatever it might be, that may have been the initial source of infection and then perforated into the peritoneal fluid. Because that is a totally different treatment. Those patients will need surgery to get the source control. So they'll need surgery to treat the initial infection. And if they don't get that surgery, the mortality approaches 100%. Similarly, you don't want your surgeons taking patients to the operating room unnecessarily. So just consider where is the source. And that's why, like you mentioned in the case, non getting a CT scan. I think you can get the paracentesis first, start antibiotics, but I would probably get a CT scan in most of these patients to make sure there's not something else going on. That brings us kind of the underlying diagnosis in this case too, which was hepatic encephalopathy. It's a clinical diagnosis, kind of a diagnosis of exclusion. Think about other causes for altered mental status or other causes of lethargy or somnolence. And if you've ruled those things out and they have known cirrhosis, then there's a decent chance they have hepatic encephalopathy. Some things that can point you towards this diagnosis is an elevated ammonia, but it's not necessary. And also, just because they have an elevated ammonia doesn't mean they automatically have hepatic encephalopathy. So it can support your diagnosis, but it's not everything. The other thing that can support is if the patient normally has 4 or 5 bowel movements a day, but now all of a sudden they're only having 1 or 2, that puts them at really high risk of hepatic encephalopathy. So asking them about change in bowel habits and stool output can be helpful. You can check for asterixis, like I mentioned, which is the flapping of the hand with outstretched arms. You treat hepatic encephalopathy with lactulose. In the ER, you'd want to give it every 1 to 2 hours until they've at least had 2 stools, but the eventual goal is that they want to have 4 stools per day. this is probably not a decision we're making in the emergency room, but if lactulose wasn't working, you would add on top of that rifaximin. So you wouldn't get rid of lactulose, you would add it to it. So then they'd be on lactulose plus rifaximin to treat their encephalopathy. Any questions about hepatic encephalopathy, paracentesis, bacterial peritonitis, or anything about the case? Anyone have any interesting cases with any of these diagnoses?
Can I, hello?
Okay.
Can I ask you? Yeah. Um, did you routinely do CT scan on your patient uh, with bacterial peritonitis, or is there any giveaway that uh, make you consider the CT scan?
I think I usually am getting a CT scan just to make sure there's not something else also going on. And also, normally I'm doing a paracentesis. If I'm really concerned, I'm starting antibiotics right away, but I might not get the analysis back on that fluid for a couple hours. And so in the meantime, I'm getting a CT scan, and it's not really delaying where they're going to end up, who's going to end up admitting them. While I'm waiting for the analysis, I can usually get the CT scan done, and then the admitting team has all the information they need to take care of the patient moving forward. If they were really unstable, um, maybe I wouldn't get a CT scan. I would definitely consider not using contrast if their creatinine was super elevated. Um,
Yes.
but if it was like just mildly elevated, I would give contrast. Yeah. Anyone else have any thoughts on that? Are you guys always doing CTs or kind of hit or miss?
Thank you for your answer.
Yeah, of course. Good question. Okay. So this is gonna be case two. So we'll need another volunteer, someone brave. Nan, what hospital do you work on? Do you work at?
I'm working at Thống Nhất Hospital in Vietnam.
All right, so how about someone from Cho Ray volunteers? Someone who works at a different hospital. Does anyone work at Cho Ray? Okay. Okay. Yeah. Okay. Thank you for letting me know. Okay, someone from UMC. Dr. Nguyen, were you saying something?
À, em here, Dr. Đại.
All right. Thank you, Dr. Haifeng Nguyen. This is your case. So it's a 60-year-old male presents with flank pain. And just like the last case, you're gonna have to ask questions to get all the information. What do you want to know right off the bat? Or first thing you want to know?
Fine. Let me see.
I'm having trouble hearing you. I think It's just very quiet.
He he has the plan pen, but right or left, please.
Say that one more time. You're a little bit more clear, but one more time.
I think he wants to know if the pen is in the left or the right side.
Okay, it's
Yeah,
a sided
yeah,
thing.
exactly. I think maybe his pen from maybe liver or kidney, maybe pancreas.
Can everyone else hear him okay, or is it just me? Okay, thank you, Dr. Dye. I'll go ahead and give you the vitals here. So vitals: heart rate 85, blood pressure 87/65. Rest are pretty normal. Yeah, this is a big guy. This is a big guy. Yeah, over 300 pounds for those who like to use the pounds. All right. Someone else, or let's just do a group discussion then. What are some thoughts on so far? What do you guys want to do next? What do you want to know about the patient?
I want to know his result, abdominal ultrasound, maybe Roth to detect hypotension.
I heard you want to know more about the history. Yeah, so it was sudden onset, sharp pain, started on the left side about 2 hours ago. He said it's been constant since it started. It is severe, 10 out of 10. He feels that he's been lightheaded since the pain started. Um, he is nauseous, but he hasn't vomited. No fevers or chills. He's pretty worried. He's saying, Doctor, I've never had pain like this before. I did have a kidney stone once, but this feels different. Um, can you help me? All right, I'm going to give you the next couple of lines here. So in this case, I think that this patient we would consider like an ABC or a critical patient. So we're going to go straight to assessing their airway, their breathing, their circulation, and then also any disabilities that they have. So I'll give you all of that stuff. So airway, he's speaking normally. Breathing, he's breathing a little bit fast, but no distress, and he does have clear lung sounds and bilaterally. For circulation, he is pale. Um, he does have 2+ distal pulses, however, and he kind of looks cold to you. Uh, from a disability standpoint, he's TCS 15. He's answering all questions appropriately and moving all extremities. And for exposure, you do look for signs of trauma and you don't see any signs. And the nurses are helping him get into a gown. What are your first actions when you see this patient who's pale? Um, sleepy, with cold skin and a hypotension.
So I want to give him two IV light and then put him on monitor as well as do a brush ultrasound.
Perfect. I think that's a great idea. So yeah, initial actions, IV. You maybe want to start some fluids and then continue to reassess, sending out the blood work, and then doing a rush exam, I think sounds perfect. Um, just some other kind of additional HPI while the nurses are getting the IVs in, someone's grabbing you the ultrasound or you're grabbing it yourself. You do find out that he has a history of hypertension and high cholesterol. He is very obese, as Dr. Dye pointed out. He's 150 kilos. He hasn't seen a doctor in a few years. He does take metoprolol, and he takes simvastatin for his high blood pressure and his high cholesterol. He's never had any surgery. He has no allergies. Um, and that is about it. Oh, he was a smoker. He smokes a pack per day for as long as he can remember. No pertinent family history, and he is full code. For a physical exam, any specific thing that people want to look at before we jump to the ultrasound? We kind of talked about some of the physical exam during our initial ABC during our primary survey. Nothing, I'll just give you guys the shortcut. Nothing else was super important. His abdomen is soft. There's no obvious tenderness actually on his abdomen. He does have some pain on his flank. He is morbidly obese. He looks pale and diaphoretic. What's on your, before we get to the ultrasound, what's on your differential diagnosis for a 60-year-old male who's presenting with flank pain, who's hypotensive, and kind of looks like they're in shock based on pale and diaphoretic? Any big life threats that you want to make sure they, anything that pops into your brain?
So it for me it's quite difficult to get correct diagnosis from this patient, but I'm thinking of something like sepsis. Uh, Also something to do with the acute coronary syndrome because of his history as well as his diaphoretic
Yeah,
experience.
I think that's great. Yeah, thinking about this could be all from the chest. This is actually a heart attack or something like that.
Heart attack and triple A.
Yeah, this could be a triple A. I think the acute coronary syndrome fits well. Triple A fits well. This patient, as we said on the physical exam, doesn't really have a lot of abdominal pain, but is hypotensive and complaining of flank pain, and those things could cause it for sure. I think additionally, this could be a kidney stone with sepsis, associated with sepsis. This could be really anything in the pelvis. In a female, you'd be thinking in a different age, maybe ectopic pregnancy, but not so much in a male. But yeah, you're thinking about all the stuff in the abdomen. This could be appendicitis that's ruptured. It could be diverticulitis that's ruptured. And then yeah, AAA ACS. Perfect. Um, you've mentioned the rush exam. Any other blood work or any medication you want to give so far to the patient? Do you want to give anything for the pain or for the nausea? I bring that up mostly because it's often difficult to treat pain in patients who are hypotensive because a lot of our, morphine, hydromorphone, things like that are going to drop the blood pressure. So being mindful of that, you could try Tylenol, but it sounds like this patient's in severe pain. That might not work. I think fentanyl would be a decent choice as well. It's pretty stable and it works quickly and then it also stops working quickly. So you could always just give a small dose and see how he reacts to it. And then you could give him another small dose to help control his pain. Any specific labs that you all want?
I think also CBC, CMP, coagulation panel, and urinary test,
Perfect.
ultrasound, and
Perfect.
also a troponin.
Perfect. Yeah. A troponin. I would add blood cultures, just because of the hypotension. This could be something from an infection still. All right, so here's your EKG. It's really, if anyone wants to interpret it, feel free. But it's actually quite unremarkable. It's a pretty normal EKG. You've got P waves, before every QRS. The intervals are normal. There's no ST segment elevation or depression. The only thing that I really notice is that the QRSs are maybe a little bit big out here, which would suggest like the known history of hypertension. He could have a little bit enlarged heart from that, but otherwise pretty normal EKG. Here's part of your fast exam. It's normal. There's no blood there. What other parts of the ultrasound do you want to look at?
It's fast negative. I would like to inspect the two kidney further more carefully for looking for the dilated of the uh, for the side of pyelonephritis if possible.
Okay. Yeah. So yeah, you want to do your fast exam. You look at the kidneys. The kidneys look normal on both sides. Someone mentioned a rush exam. What other views would you want to get for the rush exam?
I want to know the heart and aortic.
Yeah, the heart and the aorta. Perfect. The heart, it's beating kind of hyperdynamic, but otherwise normal. Here's your aorta. Anyone have any thoughts on this aorta?
More than 5 centimeters.
Yeah, it's big. It's greater than 5. That's measured down here for us in B, and on A it's 6.39. A couple quick comments on this ultrasound. You do see that there looks to be like a thick wall. Make sure that you measure from wall to wall, not just where it looks like there's the blood going through.
Ghê trời. HBI là gì?
And
History of recent units.
this could suggest actually that there's a thrombus. That this could be a clot. This could be a clot on this side here. It's hard to say for sure, but that's probably a clot. So what do you want to do now based on that aorta? I know you guys know the answer to this.
Usually in my department, if we see a very dilated aorta like that, we usually get him for the CT if he is stable enough. But if we don't, we have to give him something to control his pain first, and then lower his heart rate by using beta blocker.
Yeah, perfect. That I think is you got to get a CT scan if you can. This patient's kind of unstable, and I think we have a diagnosis. We do want to make sure that the blood pressure and the heart rate are basically normal as they can be. In an aortic dissection, you definitely want to control the heart rate even more so. in AAA rupture like this, which is this diagnosis is a AAA, not an aortic dissection. The heart rate's not as important to control, but we don't want it to be through the roof, and so that's why we help control the pain. The other things I'd want to do is make sure I had 2 large IVs. I would consult in America, we would consult vascular surgery. They're the ones who help take care of this. I think also having a discussion with the patient about goals of care and clarifying code status, because this is a very high mortality. These patients will often die in your emergency department. So you need to be prepared for them to lose pulses. And it's helpful to know in advance, like if this patient's like, no, I don't want CPR. That would be pretty helpful to know for the team. So clarifying that. So some teaching points. So thanks everyone. I know the connection was kind of bad there for a second. Thanks for helping out. Our teaching points. One thing we're going to talk about AAAs in a second, but just some like things that were specific to this case. You may have noticed that the heart rate was not elevated despite other evidence of shock. That's because the patient was on metoprolol. So it's really important, and I just want to bring this up, to pay attention to the meds that patients are on and how that might affect their vital signs and how it might affect their presentation. It's also important to pay attention to a patient's usual vital signs. So this patient is known to have hypertension. And so if they're normally 160 over 110, and now they're 105 over 70, for some people you might be like, well, that's not super low, that's okay. But for this patient, 105 over 70 is profound hypotension. They've dropped 55 points on their systolic. So pay attention to their normals, pay attention to what medication they're already on. And then always consider a really broad differential. You guys did a pretty good job of that. This could have been intra-abdominal. This could have been cardiac in nature. Or in this case, it actually ended up being a vascular issue and a ruptured AAA. And then understand the use of ultrasound and understand its limitations. So you may have expected the FAST exam to be positive in a AAA that has ruptured, but actually 80% of AAAs will rupture into the retroperitoneal space. And so your FAST exam will be negative. So just understand that ultrasound does not view the retroperitoneum. So things in that area are not going to be picked up by a FAST exam. And then just remember the whole rush exam, looking at the heart, looking at the aorta, and also, if need be, looking at the lungs for pneumothorax. And then, this is just kind of a piece of advice, but practice looking at the aorta in elderly patients frequently, even if you don't think that they're having a AAA. When an actual AAA comes in, you're going to want to get to the diagnosis fast. And if you've practiced, you're going to be able to do it really quickly. Once you've gotten good at finding the aorta, you can do this pretty quickly. It only takes about a minute or so to find the aorta and see if there's an aneurysm or not. So moving a little bit deeper into the abdominal aortic aneurysm, some risk factors for AAA. So if the patients have a bunch of these, a AAA should kind of be higher on your list of differential. All of these risk factors are simply things that make the aorta weak. So you can think of it that way. So the older you get, the weaker the aorta is. For some reason, the male gender has a higher risk of this. Family history of AAAs, smoking, hyperlipidemia or high cholesterol, hypertension, if they have atherosclerotic disease, so they have a history of coronary artery disease or peripheral vascular disease, or if they have connective tissue disease. The most common for us is Marfan syndrome as a connective tissue disease. Most AAAs rupture below the renal arteries. So on your ultrasound, you're going to usually find the aorta high up in the chest. I know you can't really see your endpoint. You're going to find it high up in the chest in the subxiphoid view, but you need to make sure you follow it down until it splits into the renal, or sorry, into the, oh my gosh, where the bifurcation, where it splits. So we can watch a video here. Did it switch screens for you all? Are you guys now seeing a video?
Yeah, it switched for us.
Okay.
Hello, my name is Jacob. down as you
And let me know if you guys can hear the audio.
to evaluate a patient for an aortic aneurysm using your ultrasound. Your probe of choice.
Can you guys hear the audio okay? Yeah, okay.
Yeah, it's clear.
Okay, perfect.
Can be
Yeah,
the
we can hear the audio.
curvilinear transducer for anything in the belly and your phased array transducer for anything in the chest. Now, the phased array transducer definitely can work in the belly as well, but you're not going to get as good of a resolution as you would with a curvilinear transducer. So the aorta, you can pretty much evaluate the entire thing. Easy to see the root of the aorta and very easy to see the abdominal aorta. Occasionally, you can get the arch and the descending aorta. They're a little bit harder to get, but they are possible. In the thoracic aorta, the size that is considered abnormally enlarged is around 4 to 4.5 centimeters. The size basically goes down as you get down into the abdominal aorta. If you want to be super accurate, there actually are nomograms to use that correlate the body surface area with the size of the aorta. However, most of us don't have the time to do this. Let's start with the thoracic aorta. So we have a parasternal long axis view over here. Over here, you see that this ascending aorta is just massive, really big aortic dilation there. This is an apical 5-chamber view. The 5th chamber right here is the aorta. You can see here, this is normal. Usually can't see a whole lot of it past the valve. Over here, we have an abnormally enlarged ascending aorta. It's actually about the same size as that left atrium there. Now let's talk about the abdominal aortic aneurysm. So if you have trouble remembering what the abnormally enlarged number is, AAA is 3 numbers. 3 centimeters is considered abnormally enlarged. Many places state to look at the abdominal aorta and measure it at its most proximal, mid, and just above the iliac bifurcation. If your patient has a AAA greater than 5 centimeters, that is considered very abnormal. That is somebody that needs an emergent surgery compared to a patient that has one that is less than 5 centimeters. It has to do with the dilation and Laplace's law. Basically, the bigger it gets, the thinner and more friable the wall of the aorta gets, making it more likely to rupture. So here is how you do the examination. Place that probe in the epigastric area, and you should get an image that looks a little bit like this. So we have our aorta over here. We have our IVC over here on the left, liver on the left, and the spine. And you want to evaluate this little guy right here. This is the aorta. You want to see how big that is. So you can measure it all the way down, down, down. Now, I'm not going to talk about all the branches of the aorta and everything that's next to it, because really all we want to know is that aorta dilated. And we want to evaluate it from the beginning of the aorta, basically as high up as we can find it, all the way down until we get to the branch of the iliacs, which you can see right there. It splits. There's one aorta here, and it splits into 2 iliacs right there. So there's one, there's another one. So this is an aortic aneurysm, pretty big thing. Now there's something you have to realize here. This right here, this has a flow in it. This all is clot. You can't just measure this thing right here. If you just measure this, you'd say, oh, it's 2 centimeters. It's not a big deal. It's less than that 3 centimeters. But in fact, you got to measure outer wall to outer wall. And you can see that this is actually a very big 7-centimeter aneurysm. Up until this point, we've only been talking about fusiform aneurysms, which are the most common by far. Saccular aneurysms definitely occur, and the reason why it's important to scan the entire aorta. So here is an aorta right here. Now this is in long axis. This is the heart over here. Here's the liver. Now imagine if we had only ultrasounded up to, let's say, here, we might have missed this little aneurysm that's all the way over here. That's why it's important to scan all the way down. Here's it a little more zoomed in. So this is a saccular aortic aneurysm. And here it is in short axis. You can see it looks pretty normal. And then you get this weird little outpouching right here. Whenever I see something that looks like this, I always turn to the longitudinal just to confirm that it is a saccular aneurysm and not just an ectatic aorta. So to recap, anything greater than about 4 centimeters in the chest is considered abnormal. Now, there's definitely a little bit of a range, and you should correlate it with a patient's body surface area if they're kind of on the cusp, kind of on the borderline. But for me, if I'm going to remember one number, it's going to be about 4 centimeters, but it can be up to 4.5 centimeters in patients that have a large body surface area. In the abdomen, basically anything greater than 3 centimeters is considered abnormal, and anything greater than 5 centimeters is considered very abnormal. That's it for this week's 5-Minute Sono. Please feel free.
All right. Hopefully everyone got to hear that pretty okay. One other thing I wanted to add that he doesn't talk about is that often when I'm doing it, there's bowel gas in the way. And so a way to get rid of the bowel gas is just gentle, constant downward pressure, and just be a little bit patient. Sometimes it takes, 5 or 10 seconds, but just hold that downward pressure and the gas will usually move to the side. So AAAs are usually asymptomatic until they rupture, which makes this kind of a hard diagnosis because they go from totally fine to nearly dead pretty quick. Occasionally, patients do have a sentinel bleed, which is a short-lived bleed that almost immediately clots. They have a little bit of sharp pain, but then it resolves. So sometimes you can ask about that, or if a patient comes in with a known AAA and they had a little bit of pain that resolved, I would be on high alert that this patient may be very close to rupturing soon, and they might want to see a vascular surgeon to get the aneurysm repaired before it ruptures. The ruptured AAAs can mimic other less severe disease, and thus it should always be considered in your diagnosis, especially in the elderly, especially if they have those risk factors that we talked about on the top of the slide. They could have abdominal pain or they could have just flank pain. They could present with syncope. They could present saying this feels like a kidney stone. It really can be a kind of change of presentation. Classically, unfortunately, only 1/3 of the patients will present that way. So the classic thing is pain. They're in shock and they have a pulsatile abdominal mass. That's only going to happen 1/3 of the time. So high alert. You can also think about listening with your stethoscope for an abdominal bruit. You can look for flank ecchymosis or periumbilical ecchymosis. That's just free fluid that has caused the bruising in those areas. And if the bleed has included the GI tract or they have an aorta enteric fistula, so they have a fistula between the aorta and the colon, they may actually have brisk hematochezia. And so their presentation actually might be just really fast rectal bleeding. The management, it's mostly get them to the OR as fast as possible. So if you have high suspicion, they're unstable, and you have a POCUS that shows that they're going straight to the OR, you don't need to do any other workup. If they are stable or the diagnosis is really uncertain, you could consider a CT. But again, these patients are very tenuous. So definitely I would talk to vascular surgery and let them know before you send them to the CT scanner, you think they have this, and you're worried about sending them to the scanner and for them to come evaluate. You do want to allow permissive hypotension. This is kind of a big one, a big thing to remember. It's similar to the shock and trauma. So in your trauma patients who come in hemorrhage, you will allow a little bit of permissive hypotension because vigorous transfusion or trying to raise that blood pressure may actually disrupt the clot or the tamponade that's keeping them alive. So as long as they're awake and alert and if they're hypotensive, it's one of those things, just live with a little bit of hypotension, and don't over resuscitate them. If you do need to resuscitate, don't give fluids, give blood if you can. Again, this is very similar to the shock and trauma, but the thought is if you're giving fluids, you're diluting all their clotting factors. So by giving them fluids, you might raise their blood pressure, but you're making it more likely that they're going to bleed because their clotting factors are less effective. If they do have any kind of anticoagulation on board, you'll want to reverse that. So things like heparin, warfarin, try to reverse that. And then again, like I mentioned, consider the code status or goals of care. If it's an 80-year-old man who's diabetic, obese, smoker, there's a really small chance this patient's going to survive, and just having an honest discussion with them about what they want us to do if they do code. So that's all I have about AAAs. I have one more slide, like I mentioned before. We're going to talk about nausea and vomiting, but any questions about that case or AAAs? All right. And if you think of any, you can ask questions at the end too. But just wanted to quickly talk about nausea and vomiting. You don't need to answer this question, but just think in your head, what is your differential for nausea and vomiting? What types of things can cause nausea and vomiting? You can think about specific diagnoses. You might prefer to think about in certain systems, things in the abdomen, things in the chest, metabolic things, medications, intracranial, infectious, traumatic. There's really a lot. And so I'm going to send this slide to you guys in an email after this lecture. But here are some things to think about in a nausea and vomiting patient. It's really broad. If they're unstable, get fluids, check a glucose. If they're a young woman, check a pregnancy test. But then you really need to think about all these boxes. Is it neurologic? Is it GI related? GU or gyne? Is it cardiac? Is it endocrine? And endocrine would include like things like DKA, electrolyte abnormalities. Is it related to a toxidrome, which could be either withdrawal from maybe alcohol, or it could be toxicity of alcohol, or any number of other things. It could be a side effect of a medication. It may be a normal dose that they took, or it could be that they took too much. So the it's really, really broad, and you really need to ask all these different questions. Things like headaches, vision changes, are they in pain anywhere, abdominal pain? Are they having associated diarrhea? Do they have flank pain or pain with urination? Um, is it exertional? Like, does the EKG look normal? How are they breathing? What kind of medications do they take? Do they have a history of, alcohol abuse or a history of suicidal ideation? So it's really broad. I'll share one case that actually happened to me last week, but I had a patient whose chief complaint was nausea and vomiting. That was what the nurses came and told us. They're like, "Hey, can you come see her? She won't stop vomiting." My resident, where I was working at the U, the resident went in first, came back out, and it's like, "I think they have food poisoning." She feels like she acutely started vomiting yesterday night after eating something strange, and she hasn't stopped vomiting since. And it didn't seem like a big deal. I went in and saw the patient and did a neuro exam, because I do consider all these things each time. And I didn't do the full exam, but I just started with, "Can you just move your eyes for me?" I noted she had really brisk nystagmus. And then I checked in the vertical orientation as well, and she had vertical nystagmus. And then I started asking her about, is she feeling like the room is spinning, or is she having vertigo symptoms? And she was like, "Yeah, yeah, a little bit, a little bit." And anyways, we ended up diagnosing her with a stroke in the posterior circulation. So her only chief complaint was really nausea and vomiting. And if I hadn't looked at her eyes, I think we would have missed this stroke. And maybe sent her home. So uh, this is kind of an approach. I'll send this out to you all. But like I said, there's not a great module for nausea and vomiting, so I just threw it into the abdominal module here. Any questions about that, or any interesting cases that you all have had? I know we're a few minutes past, so it is okay if you don't have anything good, but I would love to hear from you all and learn from you guys.
It's just a small question about a painkiller in the hypotension. To talk about the fentanyl, how about the ketamine? Did you give the ketamine for painkiller in the hypotension?
Yeah, ketamine would be a great choice. I think ketamine would be a good choice too. Yeah, that's a good one. Thanks for bringing that up. All right. Any other questions, or anyone have an interesting case, whether it was related to what we talked about today or anything else? All right. Well, that's all I've got. Thank you, everybody. Appreciate your time and your participation. If you do think of any questions, I'm always available by email, and I know everybody else as well. So I definitely don't mind having a conversation on email. If there's any strange cases or questions you all have, it's those types of questions that keep me learning. So reach out, email me. Otherwise, I'll see you all soon. Thanks, everybody.
Thank you.